Good afternoon, everyone, and welcome to this webinar hosted by the MRC's HTMR Trial Conduct Working Group. I'm Chris Rogers from the Clinical Trials and Evaluation Unit in Bristol, and it's my great pleasure to introduce my colleague Rachel Brierley, who's going to be our speaker today. Rachel is one of the trial managers within our unit and been with us quite some time now, very experienced in running a number of our trials, but today in particular she's going to tell us about the Titer II trial, the largest cardiac surgery trial that's ever been conducted solely in the UK. Rachel's presentation will last around 20 minutes and there'll be an opportunity for you to ask questions or make comments at the end of that. If you're not familiar with how to do so, we'll show you how to go about that at the end of the presentation. So now, without further ado, I'm going to hand over to you, Rachel, for you to tell us about how you managed randomisation and the treatment of patients in Titer II.
Thanks, Chris. Okay, so today, if I can get my slides to work, today I'm going to talk to you about a study where the randomization and intervention were not fixed in time and could occur at any time in the patient's post-operative period. Indeed, the intervention could occur multiple times. So we're going to focus specifically on methods that we employed to manage this to make the study a success without requiring a research presence around the clock for these patients. So a little bit about the study. The study was called Titer II. It was, as Chris said, a UK randomised controlled trial in 17 centres investigating when to transfuse red blood cells for patients who'd had heart surgery. So 3,565 patients were consented preoperatively, and then post-operatively, the patients' routine blood results were monitored by clinical staff, and patients were randomised when their HB or haemoglobin dropped below 9. And this was likely to happen in the first 24 hours post-op, but could happen at any time up until the patient was discharged. 2,003 patients were randomised into the study into either the liberal or restrictive group. So if they were randomised into the liberal group, they should have received a transfusion straight away of 1 unit of red blood cells, and then their haemoglobin level checked again by the clinical team, and then another unit transfused, and so on until they were back above the threshold of 9. If they were randomised into the restrictive group, then unless their HB was less than 7.5 when they were randomised, the intervention was to wait until their haemoglobin dropped below 7.5, and then if it did, to transfuse 1 unit of red blood cells, and again check the HB and transfuse another unit if it was still below that threshold of 7.5. Clinicians were permitted by the protocol to transfuse or refuse to transfuse in contravention to the allocation, but we asked them to document why they did so. So the HB monitoring was a round-the-clock activity. It was done using routine blood results that are done by the clinical care team, so we required support from NHS staff for the study. So as I said, it's round the clock, night and day. The most likely time for the patients to be randomised was within 24 hours of them coming back from their heart surgery, and it was quite often the case that they were randomised in the middle of the night or over the weekend when there was no research nurse cover available because funding wasn't available for full research nurse cover around the clock for the study. So we were reliant on clinical staff who were already doing these routine blood results, but we were asking them to do extra work for the study in terms of monitoring and thinking about the study as they were caring for patients. And as I'm sure you're all aware, that clinical staff were extremely busy, so we really needed to work with them and engage with them to get them to help us with the study. So how do we do this? So we needed to persuade the local team about the importance of why we were doing the research and reassure the local team that the safety of the participants was a priority. So these people weren't, they were clinical staff, so a lot of them weren't familiar with the principles of GCP, so it was really about persuading them that the safety of the participants was the priority, and one of the ways that we were able to reassure them of that was by the fact that we had written into the protocol that the clinicians could transfuse or refuse to transfuse if they felt there was a clinical need to do so. And really key to this was communication. It needed to be regular, it needed to be clear, and we needed to employ lots and lots of different methods to do it. So the main way we did this was to have research nurses acting as main facilitators for the study who communicated with local clinical staff, so nurses, anaesthetists and surgeons post-operatively, to promote a positive image of the study and to act as a focal point and reminder for clinical staff. It was so valuable to us to have engaged research nurses who were friendly and enthusiastic about the study, and each time a patient consented to take part in the study, the local research nurse would communicate this to the local clinical care teams. The research nurse locally would also complete checks on a daily basis when they were in, so Monday to Friday, to ensure that patients had been randomised and treated according to protocol, and any reasons why that hadn't happened were documented within the patient's CRFs. The protocol allowed a 24-hour window, so once the patients had become eligible by their HB dropping below 9, they could be randomised within 24 hours of that breach of that threshold. And so some that were missed overnight could be randomised the following day by the research nurse. And it was really, really important for the research nurse to go down and speak in person to the nurse caring for the patient when they came back from the theatres, because the clinical care teams in ICU are huge and they've got lots of things to think about already with these patients who are in intensive care, so they're very poorly. So it was really important to kind of go down and just help them think about the study and help them if they were unsure about anything that we were asking them to do. And we found documenting the study on handover sheets was a really helpful prompt, because often the shift changed during the night after the research nurse had gone home, and so it was really helpful if the next nurse caring for the patient was also aware of the study. And whilst the nurses tried really hard to mention it during that handover of shifts, it did sometimes get missed because there were other clinical factors that they needed to be dealing with. Regular training about the study and what was involved was delivered to clinical teams on a regular basis. This was really important due to the high usage of temporary nursing staff caring for the patients, and also due to regular staff rotations for registrars, for example. So it was vital that training was regularly delivered to maintain a high awareness of the study on the units, and also to remind them what we were asking clinical teams to do for the research, so monitoring that haemoglobin for the randomisation and then for the treatment according to the study protocol throughout the duration of the patient's post-operative hospital stay. So one of the tools that we employed liberally to do this was colour coding. And so I'm showing you a picture of the stickers that we used for the patient's notes, and you can see that we used different colours for the different stages that the patients were at. So once the patient consented to take part in the study, they were colour coded as blue, with the sticker telling the telling the local clinical care teams what they were being asked to do for that patient. And so these were stickers that went on the ICU charts, because at the time there were lots of paper charts still in use, and also we had clips that went on the front of the medical notes, which was by the patient's bedside. And then when the patient was randomised, if they were randomised into the liberal group, they had this lovely lime green sticker and clip, or they had the orange if they were in the restricted group. And we found that the colours really helped to easily identify the study patients and help the nurses to identify what we wanted them to look out for in terms of the thresholds for randomisation and treatment. We also use these in other documentation, so posters that we used about the study and information that we were giving the nurses, sort of guidelines and things like that. And we encouraged the clinical staff to take responsibility for updating the stickers and clips. So, for example, when the patient was randomised or when the charts were changed, because they were changed on a daily basis. And so we stored the stickers and clips in the nurse's manual, which I'll go on to talk about in a minute. One of the issues around this was actually, for this study, the patients were blinded to their allocation until after the end of follow-up. So we were concerned that the use of these clips being used so prominently at the end of their beds might mean that they became aware of which group they were in. So we asked patients when they were discharged from the hospital, and again in their follow-up questionnaires, whether they knew or thought they knew which group they'd been allocated to, and to measure the success of the blinding. And the majority of the patients said that they didn't know which group they were in, so it hadn't had there obviously wasn't an issue with that. So awareness and engagement of all clinical staff involved in patient care was really important to this. So from the nurse caring to the patient to the consultants, the consultant anaesthetists and the consultant surgeons and everyone in between, so persuading the clinical staff that adhering to the treatment protocol wouldn't put the patients at risk, reminding them about the caveats in the protocol, allowing treatment outside of the protocol. For example, if there was massive blood loss or if there was another clinical reason that would indicate treating outside of protocol. And we really encouraged the nurses and the doctors to document any reasons for non-adherence to protocol, and we tried to identify these the following day when the research nurses followed the unit. There was a study manual specifically designed for the clinical nurses and staff that was placed at each nurses station for each part of the post-operative care pathway, so intensive care unit, high dependency unit where they were used, and the post-operative wards. And these were really, really important. So local research teams were made aware of the clinical team aware of the presence of the manual, and the local researchers ensured that the manuals were up to date as amendments were made, because the folders contained simple information about the study, as well as a copy of the study protocol for anyone who wanted more information. And the clinical nurses were being asked to randomise patients in the overnight and at the weekend. So the study used an internet-based randomisation system. So what we did was we created a generic login for each clinical area at each site. And then the username and password for this was kept in this nurses manual at the nurses station, along with really simple and straightforward instructions for the randomisation, which was a really helpful tool when speaking to the clinical staff when the patient came back from theatre about the study. And when we asked them whether they'd randomised patients previously, we could, if they were unsure how to do it, we could go through it really easily because we'd put screenshots in the manual, so it was a quick one-to-one training session on how to randomise the patient, and it could be completed as required. And if the nurse was really busy, then we could just leave them and they could go through it later, and it was clear instructions that they could follow themselves. Another way that we used to facilitate communication was using link nurses. So these were nurses who worked in the clinical areas that were interested in research or interested in the study, and they agreed to facilitate communication and be a nominated person in the clinical area who knew about the study, so they could offer some additional support or help with randomisation or treating according to the study protocol. And to do this, we gave the link nurses additional training and contact with the local study team. And one of the things we learned from using the link nurses is that it's really important to keep them motivated and keep them engaged, to maintain their enthusiasm so that we can maintain that communication channel with the clinical areas. And then other things that we used were posters and staff rooms on wards and units to act as reminders to staff that the study was going on and what we were asking the clinical staff to do for the research. And also we found where sites had a higher throughput of patients, that made them more aware of the research that was going on and what we were asking the clinical staff to do. So it helped to maintain awareness. But really, I can't emphasise this enough. Having somebody who is the face of the study going down regularly to the unit to speak to the clinical staff who they associated with the study and could ask questions of was just a really, really vital point. So another thing that we did was we encouraged investigators meetings and through emails and regular contact with the research teams at sites for them to come up with any local initiatives that they thought would help. Where possible, we implemented these across all sites, but some of them, due to local policies, we could only have at 1 or 2 sites. So, for example, one site has an additional wristband for the study for the patient to wear to alert the doctor when a transfusion was being considered. Another site had all their research notes coloured differently, so the outside cover of the notes was pink instead of the usual brown, and that site took that further and used pink highlighter pens on the charts, and really kind of anything relating to the research, they used pink to make it clear that it was research. Ensuring explicit handover of research responsibilities amongst cardiac intensive care unit nurses. And also another site used to telephone the cardiac intensive care unit or the ward to speak to the nurses looking after the participants late at night, so 11 o'clock in the evening or over the weekends to check that they were happy with what they were doing, what they were being asked to do. So did it work? Well, I think it did work for the randomisation. So as you can see from the top table, all patients who were randomized had met the final eligibility criteria of their hemoglobin dropping below 9. You can also see that 12%, so 176 of the 1,464 participants who weren't randomized to the study, 12% of those could have been randomized, but weren't, they were missed. And a small percentage, so 3.2% of the final 2003 randomized patients were randomized late. So they should have been randomized within 24 hours of their hemoglobin dropping below 9, but actually they were randomized over the 24-hour period, outside the 24-hour period. So considering that we were doing this study at 17 sites, relying heavily on the clinical teams to help us out with the randomization, I think this is really successful, and I think it demonstrates what can be done when we work together with the clinical teams. The intervention results are a little bit more complicated because, as I've mentioned, the intervention was a repeatable event. So one breach may have been treated in accordance with the protocol, but another breach may not have done. And also we expected non-adherence. So we wrote in the protocol that doctors were permitted to override the randomised allocation if they felt for clinical reasons that it was necessary to do so. So, so at the analysis stage, a lot of thought was given to this area. And in the end, we talked about the adherence, and we came up with definitions for mild, moderate and severe adherence. So here I've put in that we have 7.9% with severe non-adherence, and what that means is they should have been transfused but weren't at all, or they shouldn't have been transfused but they did get blood. So that affected the transfusion rates. And it's really difficult to know whether the methods we employed made a difference to the transfusions according to protocol or not. But what I can say is that 7.9% severe non-adherence was consistent with the level of the non-adherence that we assumed when we were designing the study. So we weren't expecting 100% adherence rates, and that was taken into account in the calculations in the study design. And we did manage to achieve good separation between the groups in terms of both hemoglobin levels, which were maintained at about 1 gram per deciliter difference, and also between the transfusion rates, which was really important. So in summary, the key factors that I think that make a success of a study like this, where you're relying heavily on clinical staff to help you out with the randomization and the intervention, first and foremost is an engaged research nurse. It was really important for the study that the research nurse was really motivated and present. Talking to staff, caring for the participant regularly about the study and what we wanted them to do. So we needed to be really clear about what we were asking them, and regularly going and seeing them and making sure that it was something that they were aware of. Training and engagement with the study by all the clinical staff as well as the research team locally was really, really vital. So there were lots of people involved in the study, so they are acknowledged here, but obviously the local teams, especially the research nurses and my colleagues here, as well as the CI Barney Reeves and the clinical lead Gavin Murphy, and the study was funded by the NIHR HTA. Okay, so thank you very much. I'm happy to answer any questions if you have them later by email, and there's a list of some of the relevant papers that have come out for this study that you can look at if you want more details about the results. Thank you.
Okay, thank you very much, Rachel. That was very interesting, and although I know a lot about Titer2, I've certainly learnt some new aspects to it today. We do have, as Rachel said, now some time for some questions. So if you have a functional microphone or a telephone connection and you would like to speak to Rachel directly, then can you please follow the instructions and raise your hand on your screen, and then you can do that. Or alternatively, if you want to write your question in the Q&A panel, I'll read it out on your behalf. So while we wait to see if there's any questions coming in, because there's none that's appeared on my screen just yet, maybe I'll start the question and answer session, Rachel, and just a couple of thoughts. You talked about how communication was so critical and important to the success of Titer2. Did you consider at all ever using social media, for example, as a method of communication?
That's a really interesting point. We didn't, because the study took place before social media was commonly used in research. But I do think it would be really useful now, particularly given the high number of staff that we're trying to engage in the study. So we could have a study Twitter account and lots of tweets to act as a reminder about the study, and to give updates on things like the adherence rates, to try and motivate people to adhere to the study protocol as much as possible.
Yes, I think it's certainly more popular now, and we're using it in other trials. But as you say, Title II was a little while ago. Of all of the things that you talked about in terms of your communication, etc., what was the most difficult thing that you think you had to overcome?
Obviously, there were lots of things. We were trying to engage lots and lots of members of the clinical team. But one of the things that was quite challenging was that there was a high usage of bank staff, so temporary nursing staff, and also we had to deal with staff rotations, so registrars, so anaesthetist registrars in particular, kind of coming through on regular rotations. So what we did was we tried to time the training to ensure that it corresponded with the start of the rotations for the registrars, that they learned about the study at the start of their rotation. And we also obviously tried to talk directly with the nurses when they were caring for the participants. It was quite time consuming though, and it did rely quite heavily on the research nurses at sites being really engaged with the study and maintaining those good relationships with the clinical staff. We were quite fortunate at some sites that some of the research nurses on the study had previously worked in the clinical areas, so they already had good staff relationships that we could build on. But even those that weren't were very good at building relationships, and it did work very well, I think.
Okay. I haven't seen any other questions come through yet. Does anybody else on the call have anything that they would like to ask Rachel about the conduct of the trial or the challenges that she faced? Okay, well, I'm not seeing anything or any hands raised at the moment. So I think unless any come in the next couple of minutes, I'll ask just one final question, and then we'll stop there. So Rachel, whenever we do our studies, we always think, well, what might we do better or differently next time? Do you have any thoughts from Title II that if you were sort of embarking on something similar again, what you might do differently?
That's an interesting question. I think there are always ways that we can improve. I think that perhaps we would make more of an effort to kind of facilitate networks between the research nurses and kind of encourage more communication between them. We did try to do that during the study, but we weren't very successful, and I suspect with social media now that we could perhaps improve upon that. And I think that can be helpful, because where you've got lots of staff working and they're all coming up with ideas, it's really helpful to share experiences and to share tips that people come across. And I think that's applicable to all studies, not just Title II, and not just ones where the randomization and intervention are not fixed in time. I think across the board in trial management, communication is the key to success, really.
Okay, well, there aren't any further questions coming in, so I think we'll leave it there. I'd just like to say that thank everybody for joining us this afternoon, and to let everyone know that we have been recording this webinar, so it will be available shortly, and we'll be emailing you a link within the next week or so that you can listen again or pass it on to anybody who might be interested in what we've listened to today. Okay. Secondly, there will be a questionnaire at the end of the webinar, and we would very much welcome your feedback and any suggestions for future events. So please do fill it in for us. We've got a regular programme of webinars for 2017, and the next one is planned at the moment for the 19th of May, when we'll be talking to Sean Truick from the unit up in Scotland. So I think that is about it, and it just remains for me to say thank you to everyone for joining the webinar, and particularly thank you to Rachel for her presentation. Sorry, yeah?
Quickly, Citrion, there is a question from chat group. Do you
Okay.
see the...
I'm sorry, I can't see it at all.
I can see it. Did you receive any feedback from clinical staff with regards to the workload for clinicians, nurses working on the trial at weekends? No, we didn't receive any specific feedback. I think, to be honest, where the clinical staff couldn't manage to think about the study, then it was the study that just dropped off their radar. Generally, what we were asking them to do was to just have the study in mind. So most of what they were doing was monitoring their hemoglobin, which is something that they do routinely post-operatively for certainly for heart surgery patients. So it wasn't an additional task in that sense. It was just having in mind then that do they need to randomise, and if so, how do they do that? And that, randomising's a few minutes of their time, so it wasn't a huge workload that in addition to what they were doing. And then in terms of monitoring the HB for the intervention, again, they were routinely monitoring. We weren't asking them to do additional monitoring. The thing that we did ask them to do was to only transfuse 1 unit of red blood cells and then check the HB again, which wasn't always what they would do at their site. So that was additional, but I don't think there was a huge amount of extra workload. It was just getting them to remember about the study and to be aware of what we were asking them to think about, really. But like I say, if they were overwhelmed and they were prioritising the clinical stuff, then it was just that, patients didn't get randomised when they should have been, or they didn't get treated in accordance with the study protocol. And we were aware that that was going to be an issue when we designed the study, and so the calculations for the sample size took that into account. And that's why we collected so much data on adherence. Okay.
Okay. Well, thank you for that, and I apologise because the question didn't appear on my screen today, so I'm glad we've been able to answer that as well. So I think it just leaves me now to say thank you to Rachel for her presentation and for fielding the questions.
Okay. There is actually an additional one that's just come in.
Is there?
Sorry.
Oh, well, you carry on, Rachel. I'll leave you to finish off because I'm not seeing them today.
Well, I can only see one extra. So from Fang Chen, the managing clinician team are not investigators in the study, are they? No, you're right. They, the clinical care team weren't investigators in the study, although the PI at site, so the local PI, was either a surgeon, a consultant heart surgeon, or a consultant anaesthetist. So one member of the senior clinical team was an investigator in the study, and then they employed a research nurse as well. But most of the clinical team weren't. Although we encouraged the local PIs to encourage their colleagues to engage with the study, and that was one thing that we considered when we were selecting sites as well. Okay. I can't see any more questions, so Chris.
Okay.
Oh, no, hang on. There is another one from Franklin. And how often do they override the randomised transfusion strategy? There's more data in the references that I put in, so it's if you want more information, if you look at the data in the paper, or I can, once you've done that, I can look at that via email. Probably would be a better way to do that, because, as I said, there is quite a lot of data around that. And it's mild, moderate, severe intensity, and the adherence is quite a complicated thing to analyse. So it's not a quick answer, I'm afraid. Okay, thank you, Fang Chen. Okay, I think that's
any more, Rachel? Okay.
Oh, there is another one from Alison McDonald. How did you communicate the importance of clinical research to an already very busy team? So really, most of the sites that we went to do the study at were already interested in transfusion thresholds. A lot of them were restricting the transfusion, so not all of them. Some were using liberal transfusion thresholds, and that's one thing that we asked them to identify when we selected the sites. But some of them were routinely using transfusion thresholds after heart surgery of a hemoglobin of 8. but most of them realised that there's not a good evidence base, or there wasn't a good evidence base to assess when the best time was to give a transfusion post-operatively to these patients in this population. So really it was highlighting the need for the research, and then, as I said, using every communication method that we could think of at the time to try and engage with them and motivate them, and make what we were asking them to do very straightforward and hopefully not take up too much of their time. Can't see any more questions.
I can't see any more. Okay. In that case, I would just like to thank everybody for joining us today, and I hope you will join us all again next time.
Okay.
Goodbye.
Thank you. Goodbye.